Okay. Okay. So can you see my screen now?
Yes, sir.
Okay, fine. So today will discuss the modified Ponseti technique for the treatment of atypical or complex club feet. Now, we all know that the success rate of Ponseti technique across the globe is very high, with 5 to 10% relapse rates. And Ponseti, in his own series in 2002, which was published in JBJS, they found the rate of success is about 90% patients. And some of these patients, they received just like a simple idiopathic club feet. On subsequent plastering, they found that they ended up into this gross-tech deformities. You can see the dorsal skin is very puffy. There is abrasions at the bottom on the plantar surface of the first metatarsal head, hyperextended toes. There is a very severe hindfoot equinus. The heel is flush to the leg, and a plantar crease going all across. And this was different than routine club feet, which was termed as atypical or complex clubfoot. What they found is it was, while iatrogenic in many of them, but it was also present as a syndromic child at the first presentation. And in their series, they reported the rate of occurrence is 6.5% in all the club feet. So 6.5% is a huge number, and meaning that after every 15 idiopathic club feet, you might come across one atypical club feet. So we must know how to identify them, and once you identify, how to treat them differently. One needs to apply modified Ponseti technique, and I'll show you what it is. The first question is how this is different from simple idiopathic club feet. So the first difference is in idiopathic club feet, we see the heel cord is tendinous in only in the lower 1/3 of the calf, while in complex club feet, heel cord is tight and fibrotic up to the proximal third of calf. So if you feel, you can see the tendon is going all across the proximal third of the calf, and the muscle bulk is very small compared to the idiopathic ones. Supinators are weak. The inverters are weak, and so that whatever severe looking clubfoot, you do one plaster, and in next, once you open the plaster, the passive external rotation has substantially improved. That does not happen in idiopathic clubfoot. It takes 2-3 plaster to bring it to plus 30-40 degrees of external rotation. But the ones which are complex, they have weak supinators, and hence they get the external rotation corrected very quickly. And so you have to be very careful, because if you keep on doing external rotation, you may induce a midfoot break in frontal plane, and patient may develop forefoot valgus. The third is there is shortened and fibrosed quadratus plantae. The muscle which crosses the sole, it's very tight and very fibrosed. And so these patients also have forefoot equinus along with the hindfoot equinus. So if you see this clinical picture, on your left is the typical club feet where the medial plantar crease is extending only in the medial half. But in atypical or complex club feet, you will see this crease is going all across the sole. So this is the first and most evident clinical sign. And so you have to look at the sole of the foot, and you will see a deep crease is going all across the sole. So that's the first clinical sign you always see. You will see different forms of complex club feet, and the plantar creases going all across. Their soles are very grossly deformed. And this Forefoot equinus makes the foot apparently short. So you can see this is a child where on the left side is a complex clubfoot and right side is a normal foot, and the size looks very small because of the tenting of the forefoot. It is apparent short foot. Once you correct it, they assume fairly normal length. In the typical clubfoot, only forefoot part, the lateral border is fairly straight, while in atypical clubfoot you would see tenting. So you also observe from the side, and there will be tenting. One more finding which you can see is in typical clubfoot, when you see the sheen of tibia, it is fairly straight, and the heel cord is tight in the lower third. So you can see the muscle bulk in the upper two-thirds, while there is all flat in atypical clubfoot right up to the proximal third. And so you can see a flat calf till the proximal two-third. And it makes the sheen of tibia straight in typical clubfoot, while it is a cylinder-shaped or a peg-like structure of foot, which makes the plaster slippage very frequent, because it is all peg-like, it will slip off. And so you need to flex the knee more. So that I'll talk about it and when we talk about plastering. Typical club feet, the dorsum is not very puffy, while in we see the dorsum of skin is very puffy in these children with hyperextended toe. Hyperextended toe is secondary to the exaggerated cavus due to the plantar flexion of first and second metatarsal. So hyperextended toe is again a second very prominent and obvious clinical sign after a complete plantar crease. So you see in atypical club feet both the forefoot equinus and hindfoot equinus. So that is the cardinal sign of complex club feet. So this is again an example of hyperextended first toe, and as I mentioned to you, once you correct the cavus, the toe will become straight like this. Okay. This is an X-ray which shows again a midfoot break in the frontal plane. All the metatarsals are going out. This is an iatrogenic external rotation. The end point of external rotation in clubfoot plastering is not degree dependent. What I mean to say is there is a general description that you externally rotate foot by 50 to 60 degrees, and but that's not right. One should have a habit of seeing the talocalcaneum unlocking. You should externally rotate till you can feel the talus and calcaneum are unlocked and they are lying side to side. We have seen in many idiopathic club feet in about 10 to 15 degrees of external rotation also the talocalcaneal joint gets unlocked and they get ready for the tenotomy. So here, if you do not check the talocalcaneal relation, if you keep on doing external rotation, then you might induce an iatrogenic midfoot break with forefoot abduction, and you can see this radiological deformity. Yeah. Now, how to modify the technique? So we usually give about 60 to 70 degree supination. The cavus is corrected first. We use one thumb to put on the tailor head, and then we supinate the forefoot. In the first cast, it was 60 to 70 degree to completely correct the cavus to make the plantar arch straight. So there's a typical clubfoot plaster, as you can see. But in modified Ponseti technique, there is whole forefoot is down. So you don't have to lift only the first metatarsal head, but also the fourth and fifth. So you have to use two thumbs and you have to lift the whole forefoot up. And as the supinators are weak in typical club feet, we keep on doing external rotation up to 45, 50 degrees. But in atypical club feet, we never require more than 20 degrees of external rotation. Okay. And this is what I was referring to as all the metatarsals are down. You have to use two thumbs at the plantar surface with your two index fingers around the teller head, and middle fingers will go behind the heel, which will pull the heel down. And it's a this kind of maneuver which you do repeatedly. And once you keep on doing plaster with this maneuver, you will see the plantar crease will gradually get faint and it will get corrected. So this is known as two thumb technique. Your both the thumbs are under plantar surface, your index fingers are around tailor head, and your middle fingers are pulling the heel down while you lift this. So this is the maneuver you need to do, and you will eventually see the correction happening. So this is, I took picture of Dr. Ponseti. He was casting one of the complex club feet. He would push the heel down by his index finger, and this was termed as heel pulling maneuver. So he said that we have to pull the heel down. You can also do that with your middle fingers from behind. One very interesting fact, which has not been even mentioned in atypical clubfoot papers, which I learned from Dr. Ponseti, that some of these patients have absent dorsalis pedis artery. And hence, when you correct the cavus very forcefully, you may see this blanching phenomenon. The toes will go white, while in idiopathic club feet, as the dorsalis pedis is present, in some time the circulation would come back. So you wait for some time. You don't leave the correction, but you just wait and watch, and the white toes will become pink again, and that is known as blanching. But when you see this kind of blanching phenomenon in complex club feet, you have to undercorrect the foot, because some of these patients have absent dorsalis pedis artery, and if you obliterate the plantar vessels, then this child can have an avascular foot. So we cannot accept blanching phenomenon in complex club feet. You have to undercorrect your maneuver instantly, and you have to be observant about the reperfusion of the toes. And hence, we always have to keep an eye on the toes while you do complex clubfoot casting. One more modification is, as there are a very high rate of slippage due to the shape of the leg part, the plasters are done in about few more degrees more than 90 degrees. Dr. Ponseti recommended 110 degrees of knee flexion. I go about 100 degrees, but as you can see, you have to flex the knee more in order to prevent. Otherwise, it would end up into a banana-shaped plaster, and it will lead to a lot of slippage, and slippage will leave behind skin aberrations. One modification which I have been doing is to clean the plaster in a way that the great toe is covered by the plaster shelf. There is a sealing of plaster over great toe in order to prevent the hyperextension. The hyperextension corrects by correcting the or elevating the first metatarsal. Many times I see a lot of contracture of the extensor tendon, because of long-standing complex clubfoot, and there I keep this plaster sealing on, so that will keep the pressure on the great toe. Not the pressure, but it will prevent hyperextension. Tenotomy protocols are the same. One has to remember that unlike in typical clubfoot, we cannot get 15 to 20 degrees dorsiflexion in these patients. Okay, and hence, when you receive correction of a 5 to 7 degrees, when your forefoot is get corrected and the foot is come to neutral, you do the tenotomy as the same protocol we follow in idiopathic club feet. And many a times you get only up to 7 to 8 degrees of dorsiflexion. That is fine. And there you have to apply plaster. And then after plaster is removed, you have to teach the family the same maneuver that they have to do the exercises. You cannot expect 15 to 20 degrees of dorsiflexion as we expect in idiopathic club feet patients. Rarely you need a plantar fascia release. when it is very fibrotic. As I mentioned, there is quadricep plant is very fibrotic. Splint protocols, you can use whatever splint you are using. You have to keep 20 degrees of external rotation instead of 60 degrees. So this is what you need to provide to the patient. You don't need to externally rotate because then they will develop an external rotation deformity. Let me show you this technique in one of our patients. So this is a patient who had 7 plasters slipped off. We came from Indore. You can see the plantar crease. The assistant would hold the toes like this, and I will wrap the plaster over their thumb. So to prevent the crowding of the toes and keep it little wet because you need to mold this plaster well and keep the toes visible. So you can see now what I'm doing with my 2 thumbs. I'm giving pressure on the plantar surface on the head of first and fifth metatarsal, lifting it. My index fingers are around teller head. Yeah, I'm looking at the toes so that there is no blanching. And with the middle finger, I am trying to pull the heel down. So this is the maneuver you need to do. And then it's not a constant pressure, it's a punching movement. If you do constant pressure, then they will develop a plantar sore. So yeah, do this punching, multiple punching movement. Remember, you are molding the plaster, okay? You are not putting the foot in constantly. This child is not crying. So it has to be very gentle. And this will position. And once that plaster get dry, you move on to the above knee plaster. And see the knee flexion is about 100 degrees. And you mold your plaster till it becomes dry. So this was the bilateral complex club feet, and we finished casting, and it required about 5 plaster before we got complete correction. Let me show you one case. This is bilateral club feet, 7 plasters slipped off. Was done elsewhere. You will see the toes disappearing within the plaster. When patient came to us, this was a clinical picture. You can see the deep crease, hyperextended toes, and chubby skin to some extent, not very severe. Yeah, so this was the foot. You can see very chubby, and the plantar crease is going all across. This was after correcting plasters. The toe gets corrected. The dorsiflexion was improved. What I see that sometimes the plantar crease takes there will be a faint plantar crease, and it will take a few years to for it to disappear. So don't worry. As long as you have the complete correction of arch, forefoot, and hindfoot equinus, the little bit of persistent of plantar crease is not a problem. Another child, same history. You can see the foot, multiple plaster slippage, and again the sole is showing transverse crease, and it could be corrected with a tenotomy, and you can see the faint plantar crease now after correction. And there's a longer term follow up. This was the most, deformed complex clubfoot I've ever received. This child had bilateral complex club feet. As you can see, 7 plasters done elsewhere. Pressure sore at the base of head of the first metatarsal on the plantar surface. Tenting of arch, both on the medial and lateral side. Very deep plantar crease. And now there's a video made by our fellows. I hope this runs. Yeah. So this child had this simple looking club feet to start with, under 4 plasters done elsewhere. And this is when the child presented to us at 2 months. So this is an iatrogenic kind of complex club foot. And these are the pictures, as you can see, hindfoot and forefoot equinus. The lateral X-ray shows plantar flexed toes and the deep plantar crease you can see. So failure to recognize weak supinators and tendinous tender Achilles up to upper third leads to a complex clubfoot. Modified Ponseti technique was applied as I just discussed with you. One has to be patient and gradually it will get corrected. In 6 months follow-up, this feet becomes almost normal. You can see the faint crease is still there, but the foot is fine. 1 year follow-up, and this is, I think, a longer follow-up, 3 years or 4 years. Yeah, 2, 3 years follow-up, I think. And so they we can make this feet almost normal with applying modified technique. And there are patients which I've treated before 15 years. I remember I've done tibialis anterior tendon transfer because couple of them they developed dynamic supination. So even they started as in complex club feet, we corrected and they developed dynamic supination and we did tendon transfer. So how they are different in results? They need average more number of plasters at times. We see that simple idiopathic club feet gets corrected in 4 to 5 plasters. This might need more, and in some syndromic kids, it might need up to 10 plasters. Dorsal puffy skin sometimes stays, more so when we apply a splint, there is a dorsal puffy skin, but eventually it resolves, as you could see in that longer term follow-up patient. In some syndromic children, you might need a retenotomy, after some time because it's very tight, and as the child grows, the tendon may not grow as quickly. So key thing is regular physiotherapy. You have to teach family dorsiflexion just as we do in modified technique. So I teach family that you keep your both the thumbs on the plantar side, index finger around tailor head, and try to pull with your middle fingers and do this maneuver 5 times in a day, and every time you repeat it for 5 times. So that exercise, regular exercise, is very important. And relapses can happen. There are some series which have shown that 50 or 40% relapse, but still it can be managed with recasting. Very severe cases, as I mentioned earlier, you might need an open posterior release where capsules are also tight and contracted, and plantar fascia very rarely needs release. And remember, there are higher chances of plaster slippage. So you apply your casting in more than 90 degrees. Plaster breakage. So you may apply a anterior splint and skin abrasion. So be very careful and go slowly, just tell the family from the outset it might need more number of plaster. You don't need to go very fast. It will improve with time. So in conclusion, by modifying protocols, complex club feet can be corrected fully without any major surgical intervention. Yeah. So this is, I finished my talk here, and I remember my time with Dr. Ponseti in 2006, and he was a 92-year-old young man at that time. So thank you very much for your patience, and I'll be happy to take any question if you have.
Sir, I have a question.
Yes.
Yeah, sir, how do we assess talocalcaneal unlocking in these patients as the foot in these patients are much more stiffer than normal idiopathic club foot? So, how do we assess
Yeah.
talocalcaneal unlocking?
So it's a very nice question, Weber. We do it in the same way as we do in typical clubfoot. You feel the lower end of fibula, the anterior part of the lateral malleolus, and then you invert the foot and take your thumb anteriorly. The first bony prominence is stellar head.
Yes.
Okay. And then with the tip of your pulp, you will feel the stellar head, and the bottom you will feel the calcaneal tuberosity.
Hmm.
So it's the same way you feel it. You have to just invert the foot a little bit if you are not able to palpate. and then you can readily palpate the talocalcane relation. What you will see is only in 10 degrees of external rotation, the talocalcaneum relation, which was vertical, now will become horizontal. So talocalcane unlocking will happen in many patients, it happens in neutral position.
Hmm.
In some of them only 10 degrees. So I have, as you might have seen in a few cases, we do not apply plaster in more than 10 degrees of external rotation. Our degrees of external rotation depends on the point where talocalcane unlocking happens. And that should be the practice even in idiopathic club feet.
Yes. Okay, sir.
Right. Any other question?
Also, sir, many people talk about the caste holidays, but we don't get to practice that in at our.
So cast holidays is for a phenomenon which Jose Morquendo described as a compartment kind of picture where you have forced the foot. So many a times I inquire with family, how was the child's time in plaster? So if a plaster is very tight, the child will keep on crying. And when you remove the plaster, you will see the skin is shiny, swollen. That suggests that there is compartmental edema. And if you find that thing, you have to uh, give a plaster holiday, because then otherwise you may induce what's known as a compartment syndrome, and some of these patients would end up into a clawing of toes. So plaster holidays are for those patients who develop very tight, shiny, red and edematous calf as well as the forefoot. Otherwise, if you go gradual, then there is no need to give cast holiday.
Okay, sir.
So Mithun's question is, if the child is too obese, even after applying a proper above knee cast more than 90 degrees flexion, cast slips unfortunately. How often do you recommend T8 tenotomy? Yeah, that's very good question. T8 tenotomy before starting the cast manipulation. So I termed it, Mithun, as a stiff clubfoot. And stiff clubfoot is a bit different than complex clubfoot. So there were patients where the heel cord is so much tight, it's very difficult to mold around the heel, because the heel is touched to the calf. So there is no place to mold it around. And a tight heel cord is a restraint for external rotation as well. I'm talking about idiopathic club feet. And so what you will find that once you are doing external rotation, you will not move beyond 20 degrees because heel cord is extremely tight. In those cases, even though there is no talocalcine unlocking, for the ease of a proper plaster application and to improve the external rotation, a T8 tenotomy is recommended. So I've been doing T8 tenotomy in those very stiff club feet. I've seen these in arthrogrypotic children. And then once you do the tenotomy, you will see that suddenly external rotation improves, because that you can see on clubfoot model if you have, that if the heel cord is very tight, the moment you release it, it will improve. The distance improves. So that is needed. Why I am not required doing early tenotomy in complex club feet? One reason is we fail to mold the heel. We fail to mold the heel nicely. We have fear that by doing this molding, we will pressurize the skin. But once you know the anatomy, and you should be very gentle. But if you mold it around the heel well, then your plaster will not slip off. But yes, if you see that this even after molding is happening, so then you may do the tenotomy earlier. In many cases, as I mentioned, you might need another tenotomy after correction of forefoot. And remember that you don't get more than 10 degrees of dorsiflexion in these cases earlier on. If cavus improves but equinus does not, then what should be done? Yeah, so cavus improves with the casting, and equinus, the end point or the point where we do the tenotomy is when once we see the plantar crease has got quite faint and there is a arch has appeared corrected, then you go for tenotomy. And that has happened so that even after tenotomy, you have got only 5 degrees or 2, 3 degrees of dorsiflexion. That happens because posterior capsule is very tight, especially in neglected cases. Many a time, this complex club feet patients go from one to the other doctor without complete correction. And when they present to you after 3, 4 months, their capsule is very tight. And so, even after doing tenotomy, you will get only 2, 3 degrees of dorsiflexion. I call them after 10 days to do a repeat castings to stretch the capsule. And very rarely we need a posterior open capsulotomy. I don't do that. It's better to do multiple casting to stretch out the capsule because the moment we do capsulotomy, they become stiff club feet. Okay, so that's a good question, Vipin. Okay,
Sir, I
Anil,
have a query.
yes, sir. I was just asking you what your experience. Yeah, please go
Yeah.
ahead.
Sir, suppose you are primarily treating the child and you detect that the atypical clubfoot is the result of many slips. The uh,
Sorry, it's a result of.
the plaster continues to slip again and again, but we have children in which we observe that the great toe has become, you have a cast slip history once or twice, and you have a short toe developing, but the medial crease has not developed.
Okay.
Hello.
Yeah, yeah, I'm listening.
Yeah, basically the atypical club feet is forming. So
Hmm.
how to
Yeah,
deal with such situations? Shall we abort the casting or shall we turn to the modified Ponseti method in such cases?
yeah. So, so this whenever what I've seen that plaster slippage is very uncommon in idiopathic club feet. The reason is we do not do cavus and the hindfoot corrections together. In most of we try to correct cavus first and go ahead. The leg is very thin, unlike in complex club feet. But when you how to identify it is complex. So it is becoming complex is one, when you see the and subsequent follow-up, passive external corrects. You have applied plaster to correct cavus, but now you see the child is doing passive external at 20 degrees. So easy correction of forefoot adduction is the sign where it can be complex. When you see that the plaster is slipping, the toe is getting up, that means there is very stiff cavus. A stiff cavus means you have to check the sole, and if you see an evidence that it is going all across the lateral border, then you have to apply the modified technique. The key thing is you clinically palpate the talocalcan relationship. When you see this toe is going up, when you see the plaster slipping off, that means there is heel cord is very tight, and you applied modified Ponseti technique there. So applying modified Ponseti technique means that talocalcaneal joint has got unlocked in about neutral to plus 10 degrees of external rotation. Sometimes we see, the very tight heel cord and very deep cavus crease, it's not only on plantar surface, it's also on the dorsal surface, very, very severe cavus. And the general teaching to residents and young doctors is you do one plaster or two plaster and cavus gets corrected. But it is not true in these cases. I remember a child where there was a dorsal cavus, I mean dorsal deep crease, and I required 4 casts to correct the cavus, to make the medial arch straight. 4 casts. So And unless you correct it, you cannot go more externally, because then there will be residual caves. So the teaching, which is propagated is a general teaching, which happens in about 90% patients. But as Dr. Anil Agarwal said, there are some atypical cases. They are not a truly atypical clubfoot, but they have a very tight plantar, quadratus plantae. They have very tight heel cord, where you have to modify the technique according to the need. So you have to try and learn and feel the talocalcaneal relation, you know, and then you will not convert any idiopathic to complex clubfoot. Yeah. Anilji has a huge experience of club feet, and I'm sure. Do you have to add anything, Dr. Anil, in
Yeah,
complex club feet treatment
I
besides what
do
I
give
said?
cast holidays, sir.
Acha.
I do give cast holidays because whenever you detect these, I find that giving a cast holiday for 5 weeks helps.
Cast holiday for what? Once it has become this complex one, you mean?
Yes, the already established cases, because we also in our clinic see cases referred from other places.
Hmm.
So when they come, there is swelling
Yeah.
in the feet,
Yeah. So
and we
I
don't
agree.
know when the cast was removed, how many casts have slipped. So we tend to give the
Yeah.
cast holiday for 1 month, let it relapse back.
Yes, 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 yes. So that is Weber. If you are asking this, what I meant is between the complex clubfoot casting, we don't give cast holidays. But as Anil Bhai rightly mentioned, if you have received a patient who has cast slippage, and when you remove the plaster, you see that there is swelling, there is shininess, redness. At that point, you give cast holiday. It may go back to some extent. That's fine. We can correct it. But between a atypical clubfoot casting, we don't give. But yeah, if a patient has been received from other center, we give. We want to get this edema down before you start the modified Ponseti technique.
Yes, sir.
Yeah, that's perfect. All right. So thank you, everyone. I hope if you have any further question, we will discuss it on our fellows group. Weber, any other clarification? I hope it got well understood.
Yes, sir.
I wish we get a complex club within your tenure, and you can. Uh, I remember one with Weber and Charlene and Chinmay were there, so we did this recording of all this. Those videos are there in our drive, so you can have a look.
Okay, sir.
So thank you very much. Have a great day, everyone. Thanks. We'll come next week with some interesting topic. Good day.
Thank you, sir.
Yeah. Thank you, Maharshi. Yeah.